In this video, we will discuss spontaneous abortion. There are several key subtypes of spontaneous abortion that we need to be aware of for examinations. These include all of the types pictured on your screen here, as well as the septic abortion, all of which we will cover in detail. However, before we discuss each type of spontaneous abortion individually, we will first need to discuss some key principles which pertain to abortion in general. One important thing to establish before we begin our discussion of spontaneous abortion is to be able to distinguish between spontaneous abortions and intrauterine fetal demise. An intrauterine fetal demise is a fetal death which occurs at least 20 weeks of gestation. And therefore, as we move forward in the course, it is important that we use this landmark of 20 weeks, as fetal deaths which occur at least 20 weeks gestation will be intrauterine fetal demise, abbreviated here as IUFD, and those that occur at less than 20 weeks will be spontaneous abortions, which will be the focus of the remainder of this video. Therefore, the definition of an abortion is a termination of pregnancy at less than 20 weeks gestation or at a weight that is less than 500 grams. In terms of the pathophysiology of abortion, it is important to recognize that the most common cause of abortion is chromosomal abnormalities, especially during the first trimester. Additional causes of abortion include antiphospholipid antibodies, as we see in lupus, infections, as well as anatomic anomalies, especially those that involve the uterus or the fallopian tubes. In actual clinical practice, the diagnosis of abortion relies on several modalities, including the physical exam, ultrasound, and the use of beta-HCG measurements. However, often in patient vignettes, you will need to rely on 3 key components in order to clinch the diagnosis of abortion for the purposes of examinations. These components include, first of all, whether there is vaginal bleeding, second, whether there is cervical dilation, and third, whether there are products of conception present in the vaginal canal. As we move through the various subtypes of abortion, you will be able to recognize these 3 key components with ease and use them to distinguish between the various types of spontaneous abortions. As we move through each individual type of abortion, we will discuss the various principles of management for the specific subtypes in detail. However, I would like to make it clear here that there are really 3 key management pathways when it comes to managing spontaneous abortion. These include, first of all, expectant management, in which we monitor the patient with regular follow-up, but give no pharmacologic or surgical interventions. The second type of management is medical management, in which we can use a combination of mifepristone and misoprostol. This is the most common regimen for spontaneous abortion in the United States, or in some cases we can use methotrexate. Lastly, we can also utilize surgical management, including the use of the dilation and curettage, also known as a DNC, and in recent years it has become increasingly common to use a dilation and evacuation, or D&E, also known as a suction and curettage. Pictured here, we have an example of a dilation and curettage. As you can see in the image, we have a weighted speculum which ultimately opens up the vaginal canal in this downward direction here, and this allows us to ultimately use a curette in order to essentially scoop out the contents of the dead fetus from the uterus. This is what a dilation and curettage looks like, but alternatively in a dilation and evacuation, or suction curettage, rather than using this curette, you will instead see the use of a vacuum or suction instrument. And this is a procedure that you will often see in questions, but also commonly on your OB/GYN rotations. Another important principle to be aware of in the context of spontaneous abortions is recurrent pregnancy loss. By definition, recurrent pregnancy loss is when a female patient has at least 3 consecutive spontaneous abortions. As we discussed previously, the most common pathophysiology of spontaneous abortion is chromosomal abnormalities. Therefore, as part of our workup, we will need to get a karyotype in order to have an analysis of both the products of conception as well as the parent's DNA. This will ultimately be done in order to look for chromosomal anomalies. Additionally, these patients will undergo a hysterosalpingogram in order to look at the anatomy of the uterus as well as the fallopian tubes. We have an example of a hysterosalpingogram at the bottom right-hand corner of the presentation, where you can see that this dye has been injected in order to demonstrate that indeed these fallopian tubes are patent. If they were scarred over, for example, in a patient with a history of pelvic inflammatory disease, then we wouldn't be able to see this contrast material flowing freely through these fallopian tubes. And lastly, in patients with recurrent pregnancy loss, it is also standard to, of course, get lupus anticoagulant studies in order to look for the presence of antiphospholipid antibodies, as seen in the antiphospholipid antibody syndrome common in patients with lupus. Furthermore, and you will see this slide frequently throughout our OB/GYN video series, it is important to recognize the indications for the use of anti-D immune globulin. We have a separate video in our course on isoimmunization, but just to review here, the indications for anti-D immune globulin include routine prenatal care at 28 to 32 weeks, the delivery of an Rh-positive baby, ectopic pregnancy, abdominal or pelvic trauma in a pregnant woman, second and third trimester bleeding, invasive screening methods including amniocentesis and chorionic villus sampling, external cephalic version, as well as abortion, and therefore it is important to recognize that abortion is indeed an indication for the use of anti-D immune globulin in those patients who are at risk for isoimmunization. Moving on to the first of our spontaneous abortion subtypes, we have threatened abortion. This will of course occur in a pregnant woman who is less than 20 weeks gestation, as that is our cutoff for spontaneous abortion as opposed to intrauterine fetal demise. These patients in board vignettes will present with vaginal bleeding, a closed cervix, as well as no products of conception present in the vaginal canal. We have a schematic of this in the center of the presentation where you can clearly see that there is the presence of vaginal bleeding, the cervix is closed, and there are clearly no products of conception in the vaginal canal. It is almost as if the fetus, which is still present within the uterus, is threatening to abort, hence the name threatened abortion. However, with the cervix closed and no products of conception present in the vaginal canal, we cannot say that this is an inevitable abortion or that this is an incomplete abortion. We still have the products of conception present within the uterus, and therefore this is only a threatened abortion. As we said previously on physical exam, when we perform our speculum examination, there will be bleeding present in the vaginal canal. However, there will be no products of conception in the vaginal canal. Classically, on ultrasound in these patients, we will actually be able to see a viable fetus with a fetal heartbeat, and this is consistent with a threatened abortion, which will not necessarily result in an actual full-blown abortion. Therefore, in these patients, the next step in management is going to be expectant management as well as pelvic rest, so that we do not disturb this viable fetus that is still present within the uterus and still has a chance of survival. In addition, we will need to get serial beta-HCG measurements in these patients in order to monitor these threatened abortions for possible progression to our next type of spontaneous abortion. This next type of spontaneous abortion is an inevitable abortion. Once again, consistent with our definition of a spontaneous abortion, this will occur in a pregnant woman who is less than 20 weeks gestation. The patient will classically present with bleeding and cramping, a dilated cervix, and once again, no products of conception in the vaginal canal. As we take a look at our schematic on the right-hand side of the presentation, we can see that there is indeed bleeding into the vaginal canal. Additionally, there are no products of conception in the vaginal canal. However, we need to note here that the cervix is indeed open. Therefore, one could argue that if there is vaginal bleeding as well as an open cervix, that is essentially inevitable that an abortion is going to occur, hence the name inevitable abortion. When we perform a speculum exam in these patients, we are going to see blood but no products of conception present in the vaginal canal. Classically, on ultrasound in these patients, we will see a gestational sac that is present in the lower uterus. This should really make sense to us in the context of an inevitable abortion, because one can imagine that the products of conception of the fetus are present in the lower uterus and essentially pushing up and opening the cervix, thus making it inevitable that an abortion will occur at some point in time. In these patients, if fetal heart tones are still present, then there is still a chance of this fetus surviving, and therefore we proceed with expectant management. However, if fetal heart tones are absent, then we can proceed with medical management with the use of misoprostol in combination with mifepristone. And lastly, if the patient is unstable and is hypotensive and tachycardic, then we can give these patients IV fluids and proceed with a suction and curettage procedure in order to remove the fetal contents and prevent our patients from progressing to more serious complications such as a septic abortion. In an incomplete abortion, our patient once again is going to be a pregnant woman who is less than 20 weeks gestation. She will present with vaginal bleeding and cramping, as well as a dilated cervix. So far, this is similar to our inevitable abortion. However, in the case of an incomplete abortion, there will be products of conception present in the vaginal or endocervical canal on physical exam. And therefore, we can now state with certainty that this is not simply an abortion that is inevitable, but rather it is an incomplete abortion where some products of conception are still remaining within the endometrial cavity, whereas other products of conception have already made their way into the endocervical and vaginal canal. And this is the hallmark of incomplete abortion. Consistent with this, on speculum exam, these patients will have products of conception in the vaginal canal. Additionally, on ultrasound, because there may still be some remaining products of conception within the endometrial cavity, these patients may or may not have products of conception on ultrasound still present in the uterus. As is typical for our management of spontaneous abortion in general, if a patient with an incomplete abortion is stable, then we can proceed with medical therapy, including misoprostol along with mifepristone. However, if the patient is unstable, then we can ultimately give IV fluid resuscitation and proceed with a suction curettage in order to remove the remaining fetal contents and prevent potential progression to septic abortion and other complications. Moving on to a complete abortion, this will once again be a woman who is less than 20 weeks gestation. The patient may or may not recall having a history of vaginal bleeding. The patient will classically have a closed cervix. And because this is a complete abortion, the products of conception will be completely expelled, and therefore there may even be a visible mass protruding into the vagina. This is consistent with our schematic on the right-hand side of the presentation, where we can clearly see that there are no remaining products of conception in the endometrial cavity, and rather there are products of conception which are now present in the vaginal canal. And this is ultimately what distinguishes an incomplete abortion, where we may still have some products of conception in the endometrial cavity, from a complete abortion in which these products of conception have been entirely expelled. Classically, in addition to a visible protruding mass in the vaginal canal, on speculum exam in these patients, we may also sometimes see blood present in the vaginal canal. And if we were to perform an ultrasound, we would ultimately see that the endometrial cavity is empty, consistent with the fact that this is a complete abortion and the products of conception have been completely expelled. To our knowledge, in these patients, the products of conception have been completely expelled, and therefore we can proceed with expectant management and monitoring of serial beta HCGs. The idea here being that there are no remaining products of conception, and therefore we do not need to worry about remaining products proceeding to septic abortion or other complications. However, if we do feel that there are indeed remaining products of conception that may be present in the endometrial cavity, then we can proceed with a suction curettage. Another very high-yield subtype of spontaneous abortion is the missed abortion. Once again, this will be a pregnant woman who is less than 20 weeks gestation, and classically this will present with a loss of early pregnancy symptoms. While we discuss normal pregnancy in detail in subsequent videos, women classically have several physiologic changes, one of the most common of which is nausea. One of the classic presentations of a missed abortion is for a patient to initially have nausea or other symptoms of early pregnancy and to lose these symptoms, raising our suspicion that we may have missed an abortion in this patient. For the purposes of examinations, these patients will typically present with no vaginal bleeding, a closed cervix, and no products of conception in the vaginal canal. This is consistent with our image on the right-hand side of our presentation, where we essentially just have this dead fetus still present inside the endometrial cavity. However, cervical dilation and vaginal bleeding will classically be absent in patients with a missed abortion. When we perform a speculum exam in patients with a missed abortion, we will see no blood and no products of conception present in the vaginal canal. Instead, if we were to perform an ultrasound in these patients, we would see that there are still products of conception present in the uterine cavity, not the vaginal canal, and we would also see that these patients classically have an absence of fetal cardiac activity, indicating that the fetus remaining in the uterus is no longer viable, and that we have indeed missed the abortion. These patients have multiple options in terms of their management. We can proceed with expectant management with serial beta HCG monitoring, and essentially wait for the patient to dispel this dead fetus naturally. However, if the patient and physician decide together that they want to remove this dead fetus, then we can proceed with a suction curettage. Moving on to a septic abortion, our classic patient in this case will once again be a pregnant woman. However, she will present with fever and abdominal pain. In addition, these patients will classically have a recent history of an elective abortion or a history of a missed or incomplete abortion. This is consistent with the underlying pathophysiology of septic abortions, which is most commonly a non-sterile elective abortion. In this case, there are going to be retained products of conception, which ultimately become infected, leading to the development of a septic abortion, which is very much a feared complication of spontaneous abortions and is considered to be a medical emergency. On physical exam, patients with a septic abortion will classically have a dilated cervix, and when we perform our speculum exam, they will classically have purulent, bloody, and malodorous discharge. Additionally, because the pathophysiology of a septic abortion is retained products of conception, we will be able to see these retained products of conception on ultrasound, and this may also be described on ultrasound as having a thickened endometrial stripe. In terms of management, if we suspect endometritis in a patient with a septic abortion, then we should ultimately obtain blood and endometrial cultures. After obtaining these cultures, we can treat these patients first with broad-spectrum antibiotics, and after we begin antibiotic therapy, we can proceed with a suction curettage in order to remove any remaining products of conception that may be infected and leading to this septic abortion. I would also like to take a moment here to comment on a term that is commonly used in OBGYN question stems, which is this idea of the boggy uterus. When we say boggy, we are referring to something that is soft and flaccid, and there are really three classic scenarios where we see this in question stems when it comes to obstetrics and gynecology. The first classic scenario, which we see in the setting of postpartum hemorrhage, is uterine atony, which we discuss in detail in our postpartum hemorrhage section. We can also classically see a boggy uterus in our patients with adenomyosis. And lastly, and important for our purposes here, you can also see this soft, flaccid, boggy uterus in question stems in the context of patients with septic abortion. In this series, we have covered several high-yield subtypes of spontaneous abortion, including those which are pictured here, as well as the septic abortion. I have now included here some of the high-yield take-home points for each type of spontaneous abortion in order to help you distinguish between our different subtypes. In a threatened abortion, we will see vaginal bleeding. However, the cervix is closed and there are no products of conception in the vaginal canal. In an inevitable abortion, the abortion is inevitable, and therefore we will see vaginal bleeding, a dilated cervix. However, there are not yet products of conception in the vaginal canal. In an incomplete abortion, we will see vaginal bleeding, a dilated cervix, and because this is an incomplete abortion, some products of conception will be in the vaginal canal, and some products of conception will still be remaining in the endometrial cavity. This is in contrast to a complete abortion in which the products of conception are no longer present in the endometrial cavity, and now these products of conception are in the vaginal canal, classically as a visible mass. This is in contrast to our patients with missed abortions who simply have a dead fetus that is still present within the endometrial cavity. And this is something that we will be able to see as a finding on ultrasound as either retained products of conception or a thickened endometrial stripe. It is also important to keep in mind that once we reach the point of a complete or a missed abortion, that there will be an absence of fetal heart rate activity, as at that point we have essentially reached the point of no return, where there is really no chance of survival of the fetus. If you simply keep in mind the three key features of vaginal bleeding, cervical dilation, and products of conception in the vaginal canal, then you will be well on your way to diagnosing and differentiating the various subtypes of spontaneous abortion. This is BoardsMD, and this is spontaneous abortion.